Welcome to this video where we are going to be talking about sample collection, test requests, guidelines, and diagnosis modalities in precision oncology in gastric cancer. The introduction of targeted therapies in gastric cancer is improving the outcomes of a cancer that has poor prognosis. These targeted therapies rely on biomarkers such as HER2, mismatch repair, MMR, and PD-1 status, but also on emerging ones such as Claudin 18.2 and FGFR2b. International guidelines recommend knowing HER2 and PD-1 status in patients with metastatic gastric cancer to tailor first-line treatment in combination with chemotherapy, but also mismatch repair deficiency, DMMR, for second-line treatments with immune checkpoint inhibitors. Results on biomarker status might not be immediately used to guide treatment decisions in all cases, as recommendations are focused in advanced or metastatic gastric cancer. But while there is not always a direct clinical implication, excepted for localized disease with MMR status, biomarker testing should be done for every gastric cancer patient as soon as the diagnosis is made due to the high risk of relapses and tissue exhaustion. The current biomarkers in use are evaluated using mainly immunohistochemistry or in situ hybridization techniques that can also be used to evaluate the emerging biomarkers. NGS testing may also be used if the molecular tumor board recommends testing for other possible alterations such as NTRK. But while different techniques can be used, tissue reflex testing is the recommended approach as optimized clinical decision by giving a quick and complete information as well as reducing tissue exhaustion. There are a number of challenges that can arise during gastric biomarker testing, and it is important to recognize these to help reduce pre-analytical errors. Recognizing and overcoming problems during identification of the sample, test request, obtaining sufficient sample, and giving the correct clinical data are important to ensure the sample received in the pathology department can be used. It is key to ensure good collaboration and communication of the team responsible for sample clinic collection, including the pathologist or local clinical staff. There are also challenges that can happen in the pathology department during fixation, sectioning, and storage of the sample, where pathology staff should follow the clinical guidelines and recommendations so as not to affect the quality of the tissue obtained. If reflex testing is not initially performed, it is recommended to identify which are the most optimal sample or blocks for downstream testing and to record in the pathology report for future reference if more testing is needed. Moreover, immunohistochemistry should ideally be performed on recently cut sections. We hope you found this useful. You can find more detailed slides for download on the Car2Head website.